Here's a question that matters more than you might think. Are you taking aspirin every day without a doctor telling you to? Millions of people do, convinced that keeping their blood thin is doing their heart a favor. The idea sounds logical, but the science has changed dramatically, and what's emerged is a warning that most people taking daily aspirin have never heard. A large-scale study found that taking low-dose aspirin, just 100 milligrams daily for several years, increases the risk of brain bleeding by 38%, not by a small margin. 38%. In 2022, updated international guidelines stated plainly that adults 60 and older who have never had a heart attack or stroke should not start taking daily aspirin for prevention. The bleeding risk now outweighs the cardiovascular benefit for this group. This doesn't mean aspirin is a dangerous drug. It means aspirin is the right drug for some people, and the wrong drug for others. And the line between those two groups is precise. Today I'm going to tell you exactly which side of that line you're on. First, understand what aspirin actually does. Your blood contains platelets, tiny cells that clump together to stop bleeding. When a vessel is damaged, that clumping process can also happen inside blood vessels, forming clots that block blood flow to the heart or brain, causing a heart attack or stroke. Aspirin irreversibly blocks an enzyme called COX, which prevents the production of thromboxane A2, a compound that triggers platelets to clump. Fewer clumps, fewer clots. That sounds like pure benefit until you realize aspirin doesn't selectively thin blood, only where you don't want clots. It reduces the body's ability to stop bleeding everywhere. That's the double-edged blade. The Aspirin trial exposed just how sharp that other edge is. Over 19,000 healthy adults 65 and older, no prior cardiovascular disease, were given daily low-dose aspirin and followed for years. The aspirin group had higher all-cause mortality than the placebo group. Major bleeding events were significantly more frequent, and in a result that stunned researchers, cancer incidence and cancer mortality were also elevated in the aspirin group. Aspirin provided no meaningful cardiovascular protection in this healthy, elderly population and caused measurable harm. This single trial reshaped guidelines across the world. On top of that, low-dose aspirin raises gastrointestinal bleeding risk by up to 60%. Through suppression of the prostaglandins that protect the stomach lining, GI bleeds often have no obvious early symptoms. Mild discomfort that slowly progresses until a serious hemorrhage is discovered. Chronic silent GI bleeding can cause anemia that drags on for months undetected. So who absolutely should take aspirin? The answer is people using it for secondary prevention. Those who have already experienced a cardiovascular event. If you have had a heart attack, an ischemic stroke, a transient ischemic attack, a coronary stent, bypass surgery, or peripheral artery disease, aspirin's protective effect against recurrence has been clearly demonstrated. For you, the benefit decisively outweighs the bleeding risk. And if you are in this group, stopping aspirin without medical supervision is dangerous. Research confirms that abruptly discontinuing aspirin in people with established cardiovascular disease triggers a rebound effect. Platelets become hyperactivated, temporarily raising clot risk above baseline. Clinical reports document heart attacks and strokes occurring within days to weeks of unsupervised aspirin discontinuation. For stent patients specifically, abrupt aspirin withdrawal can lead to stent thrombosis, a sudden and potentially fatal clotting of the stent. If you take aspirin for a cardiac history, do not stop without speaking to your cardiologist first. For primary prevention, people who have never had a cardiovascular event, the current guidance is clear. Adults 60 and older should not start daily aspirin for prevention. The bleeding risk exceeds the benefit. Adults 40 to 59 with a 10-year cardiovascular risk of 10% or higher may consider aspirin after individual discussion with a doctor, factoring in bleeding risk. Below age 40, there is no evidence supporting aspirin for cardiovascular prevention. Having diabetes or high blood pressure alone does not make aspirin appropriate. Many people taking aspirin daily began because of those exact conditions, and that is the group most likely to be taking it unnecessarily. If you are currently taking aspirin without a prescription, and without a prior cardiovascular event, do not stop abruptly on your own. Instead, make an appointment with your doctor this week. And ask specifically whether aspirin is appropriate for your individual situation. Let your doctor assess your cardiovascular risk and your bleeding risk together before any decision is made. For those legitimately prescribed aspirin, several practical rules matter enormously. Always take it with food, or immediately after eating, never on an empty stomach. Enteric-coated aspirin reduces gastric irritation. Take it with at least 7 ounces of water in an upright position. Consistency of timing matters more than whether you take it morning or night. If you take ibuprofen or naproxen for pain, take aspirin first and wait at least 2 hours before taking ibuprofen otherwise. Ibuprofen occupies the COX enzyme first and blocks aspirin's platelet effect entirely. Alcohol and aspirin together is a dangerous combination. Regular drinking alongside aspirin significantly multiplies gastrointestinal bleeding risk. If you take aspirin, alcohol should be minimized or eliminated. Never combine aspirin with anticoagulants like warfarin or dabigatran. Without explicit medical supervision, the combined bleeding risk can be severe. Before any dental procedure, endoscopy, or surgery, tell the provider you take aspirin, because aspirin's platelet suppression is irreversible. Full platelet function recovery takes 7 to 10 days after stopping. The decision to pause or continue aspirin around procedures must be made by your doctor, not by you alone. Monitor yourself for bleeding warning signs: unusual bruising, cuts that bleed longer than normal, pink or red urine, black or tarry stools, frequent nosebleeds, bleeding gums. These require medical attention promptly. If you take aspirin and suffer a head injury of any kind, even one that feels minor, seek a CT scan. Intracranial bleeding in an aspirin user can progress rapidly with no initial symptoms. Keep blood pressure well controlled. Uncontrolled hypertension combined with aspirin dramatically elevates stroke risk. A blood pressure target below 130 is a critical safety condition for anyone on aspirin therapy. The bottom line: aspirin is a life-saving medication for people who have already had cardiovascular events, and a potentially harmful one for those who haven't. If you've had a heart attack or stroke, never stop without your doctor's guidance. If you haven't, and you're over 60, please find out this week whether you actually need to be taking it. That 38% increase in brain bleeding risk is a number that belongs in your decision, not missing from it. Subscribe and like if this helped you. Share it with anyone you know who takes aspirin daily. In the next video, I'll cover why blood pressure medication stops working for some people, and the foods that silently block it from doing its job.